I'll never forget the way our Central IP President, Neelam Mohan, introduced Kashi sir. Karnataka, King Kashi. So I now call upon King Kashi sir to please summarize and tell us the take-home points of today's presentation.
Karnataka King Kashi.
Just I was telling him, no, instead of Kashi Vishwanath, we can call him Kashi Vaccinath.
Thank you. I have a small confession to make. Throughout my career, right from the time I entered MBBS till 2 p.m. today, I have never listened to any postprandial session with such rapt attention as I have. For the simple reason I have to summarize, and I've been busy doing that. Okay.
Was it a compulsion?
Next session I am not agreeing for this. Okay. Well, we had 3 talks, but I think we had something equally important before the talks, and that is the invocation by Dr. Srilekha, who spoke about prana. And I think those who are aware, prana is a very essential essence of physical, mental and spiritual well-being. And thanks to you for bringing out this so well. We come to Dr. Pranita's talk. Very good and comprehensive talk. She spoke about the differing definitions. And I think for the clinician also, the definition varies by how busy he is and what stage of the career is reached. For someone doing MD, PG, fever, cough, maybe chest pain, you talk about decreased air entry, increased tactile vocal fermenters, bronchial breathing, pneumonia. But for us, fever, cough, you put your chest, stethoscope, you have some crackles localized, pneumonia. I'm sure you all agree with that. So it will depend upon our stage of practice also. She spoke about the differing definitions, apart from what I have said, the pathological classification, microbiological definition, radiological and clinical. She also very well pointed out the limitations of radiological diagnosis, because radiology does not essentially link to the etiology. We must remember that the WHO has brought out certain case definitions for radiological diagnosis, and that was mainly made for the purpose of vaccine studies, where basically a consolidation patch which is more than 2.5 or more centimeters in diameter has a very high probability of being pneumococcal. So there is some relationship, but not something that can be vouched for. She spoke about the importance of ultrasound and CT, and here I think ultrasound today, or maybe the next few years, every clinician will be having a pocket ultrasound along with the stethoscope. That is going to be the importance of ultrasound in the very, very near future. And especially for respiratory, I think people are going to stop taking X-rays and diagnose it only with an ultrasound. Not just the empyema, diagnosis of pneumonia as such. A lot of work being coming out in that. She also spoke about the clinical case definitions of no pneumonia, pneumonia and severe pneumonia. She also discussed the shortcomings of the WHO definition. I mean, it does not have, it has a very high sensitivity but very low specificity. You will pick up all the pneumonia, but you're going to pick up a lot more things apart from pneumonia because they are under the WHO case definitions. She spoke about the changes of pneumonia mortality. She showed that graph so well. Here I would just like to emphasize that we all believe that vaccines have brought down the pneumonias. Let me tell you, the decline began at least 25-30 years before the onset of vaccines, and that has been because of environmental control. I think when I talked the last talk about prevention, I'm going to talk something about it. She spoke about the PREPARE study. She spoke about the different risk factors, and there she emphasized the importance of childhood undernutrition, a very high risk factor for both mortality and morbidity of pneumonia. She spoke about neonatal pneumonias, congenital pneumonias. If I've missed out anything, those are the probably short few seconds where I involuntarily dozed off. Okay, thank you. It was a very good talk, very comprehensive talk, and I request Manju to please share all these presentations in the group. I hope the PPTs. It will be very useful for us also. Right? Now next we come to Dr. Manju. Very nice talk. He spoke about the etiological agents of LRI, especially the difference in those below 3 months and those above 3 months of age. And the fact that this is essential because that is going to decide the empiric antibiotic therapy that we are going to start with. I'm very glad he discussed the PERT study. If you remember, before we started using the pneumococcal antibiotic, we spoke about one study called authored by one Igor Rudan, 2008. I don't know how much of you all remember. It's a pie diagram. One half is bacterial. Of the bacterial, 2/3 is pneumococcus, 1/3 is Hib. And based on that study, the WHO said that all low-income countries should introduce pneumococcal vaccines also. Now this PERT study, which was done about 12 years later, has shown the impact of that intervention. Today, in that PERT study, only 12% of severe hospitalized pneumonia were due to pneumococci, 31% RSV, 61% viruses. And as he said, more severe the cause of pneumonia, the role of bacteria increases, but still viruses are more common than bacteria. But the role of bacteria definitely comes down to almost 29% as far as the streptococcal pneumonia is concerned.
Secondary infection or echo infection or both?
No, these are primary pneumonias. Primary pneumonias only.
They are combined, viral and bacterial.
See, those can occur. Combination is more common where a bacterial infection is superimposed upon a viral infection. In fact, a study has shown that pneumococcal vaccination has reduced both influenza and COVID mortality.
Right.
Because of the co-infections that are occurring. Okay? Now, blood culture, I think, is something 3.2%. That also is very high, I think, compared to our experiences. He also spoke about the CAPE study, the differences between the adults and the kids. Then he spoke about vaccines and changes in etiology. A brief mention that there are 100 types of pneumococci, almost 50 or 60 cause disease, and we have a vaccine only against 13.
14.
This nasopharynx, from which pneumonia occurs, there are no vacant slots. The moment one is gone, there's another one to come and sit in. So replacement occurs very rapidly, and that's the reason why from 7 we went to 10 to 13 to 20 and now 24, 28. Even there are 31 variant also is now being tried. Okay. He spoke about the 4 types of pneumonias and manifestation of different stages of local pneumonia. He spoke about bronchopneumonia, interstitial pneumonia, and biliary. So I hope I haven't missed out anything from what you said. Manju? Right. Now last was Glance, very flamboyant talk. He spoke about the different classifications, anatomical, etiological, based on the clinical setting, based on the age and the cigarette. And I think the bottom line of that, which he clearly emphasized, is this classification is essential for empiric initial antibiotic therapy. I think this is an excellent point here brought out. And that's the reason why we need to classify. And he spoke about the different epidemiological context, he spoke about the clinical severity, and he finally crowned it all with that particular case scenario, which was an application of all the knowledge that we have gained. So I think that's it. Thanks a lot. We have had an excellent session. Thank you, Nagesh, and we have really made this thing happen. Thank you. Thank you.
Thank you.